Hello and welcome. Thank you for joining us today for our final presentation for National Rural Health Day, where we focus on the power of rural. My name is Dr. Hana Hinkle, and I'm so pleased to be joined today with my friend and colleague, Dr. Alesia Jones. We will be talking about diversity and inclusion efforts at the University of Illinois College of Medicine Rockford, and really beyond, focusing on our communities as an extension of our campus as well. Before we get started, I'll start with introductions. I'm the Associate Director for the National Center for Rural Health Professions and a Research Assistant Professor at the University of Illinois College of Medicine, Rockford. I also serve as the President-elect of the Illinois Public Health Association. And with me again, as I mentioned, is Dr. Jones. Could you say a few words about yourself?
Sure. Hi, thank you. So I'm the Interim Assistant Dean for Diversity and Inclusion for our Office for Diversity and Inclusion on our campus at University of Illinois College of Medicine, Rockford. I'm also a licensed clinical psychologist, and I serve as the Associate Professor for the Department of Family and Community Medicine, as well as serve as our Director for our Behavioral Science curriculum for our Family Medicine Residency program.
Wonderful. So as you can see, Dr. Jones and I wear a lot of hats, but our passion is always in diversity and inclusion efforts as well. And so we'll be highlighting some of that work today. So first, I wanted to talk about the National Center for Rural Health Professions, or NCRHP. This is a center that we're very proud of, that's housed on our Rockford campus. It was established in 2003, and it really strives to meet the healthcare needs of rural residents and their communities in Illinois and around the nation. We do a lot of work around education, research, and policy. But as part of our mission, we really work to recruit and retain underserved rural residents and students, including racial and ethnic minorities, to train in health professions and to one day hopefully practice in a similar community to where they're from. We wanted to point out in this conversation today that rural America is not homogenous at all. It consists of racial, gender, ethnic minorities, and other minority groups. And so we're very mindful of the diversity with the communities that we engage in for our work. We wanted to share this quote here. It says, "Rural America has been home throughout its history to large numbers of racial and ethnic minorities." And we'll show you a slide here coming up that shows sort of the breakdown of what those racial categories will look like. But there's also sizable populations of people of color, immigrants, LGBTQI people, and other vulnerable populations, including veterans, that we've all tried to outreach and work with. This slide, as I mentioned earlier, demonstrates a distribution of people of color across the rural-urban spectrum. We wanted to point this out because this is really a way that we categorize how rural somebody is when we look to recruit them into our programs, and also how we engage with those types of communities as well. So below you can see that there is numbers on the x-axis that show how metropolitan or how urban a community might be and where their distribution of people of color lies. So when we're using this system, it's called a RUCA code. It's from the USDA, and it stands for Rural Urban Commuting Codes. As a RUCA code is the most urban you can be, and we tend to try to recruit students into our programs that are from RUCA codes 4 or higher. So as you move down this axis, you can see that the distribution of minorities is still significant. However, this geographic region becomes more rural. As part of our efforts for the National Center for Rural Health Professions, we have really tried to increase our programming to meet the diverse needs of rural populations in the state and in the nation. Some of the work that we've done has been funded by the federal government through HRSA, and others has been done through private foundation funding. But again, we remain committed to doing this work. An example of some of the programs that have been successful for us in the past include the HRSA-funded Rural Medicina Academy, where we worked as an extension of the Hispanic Center of Excellence, the UIC campus in Chicago. And we really tried to outreach to high Latinx populations across the state of Illinois, and try to do some more development and pipeline work, as we like to call it, for students who might not necessarily be aware of the different options that they might have to be a health professional one day, but we provide education and training and mentorship through programs like the Rural Medicine Academy to help these students recognize their potential and to achieve their dreams. We also, as part of the Rural Medicine Academy, offered an intensive summer scholars program. This again was focused on students of color from the area surrounding Rockford and in the city of Rockford itself, to try to, again, mentor students and give them opportunities to learn and create and develop professionally and personally as they start considering options for their educational pathway. And we hope that they consider options in the health professions. Academia de Padres is something that we are also very proud of to be able to offer, again, as an extension of our Rural Medicina Academy. We recognize that a lot of the students that we interact with might be first generation students and might not necessarily have sort of the background and knowledge from their family or their community where they can actually better understand what they need to do to be able to be successful in the health profession. So the Academia de Padres was really critical for us in terms of being able to offer education and training to parents of first generation or racial and ethnic minority students across the state, and help educate the parents to help them understand how they can best support their student as they move forward in their educational career. And then other sort of activities that we have been able to partner with include some work that we've done through our Illinois Area Health Education Center Network program, which is a nearly $7 million federal grant that we've received to do programs very similar to what we're describing here, with, again, the goal of to recruit and retain underrepresented minority students to serve in underserved communities as they become healthcare providers. So the Black Men in White Coats Youth Summit was done really in response to some of the other sort of activities around recognizing how racism, discrimination, and bias can really impact health outcomes. And so we engaged and mobilized with a number of partners in Chicago to try to, highlight some of the work that needs to be done around reducing disparities, particularly between a patient and provider in a healthcare setting. So before I turn it over to Dr. Jones, I did want to highlight that the work that we do through the National Center through Rural Health Professions is really ultimately aligned with the diversity and inclusion efforts at the UIC College of Medicine Rockford. I was very privileged to be able to serve as a co-chair for our Ad Hoc Committee for Diversity and Inclusion that we established in June of 2020. And Dr. Jones, as interim assistant dean of diversity and inclusion on our campus, was also a co-chair with me as well. So Dr. Jones, the floor is yours.
Great, thank you, Hannah. So this portion of the presentation, I'll be describing our diversity and inclusion efforts on our campus. Across the US, medical students have raised concerns and described racism, discrimination, and bias they've experienced on their medical school campuses. So we are not on this journey alone. However, we have responded very quickly and are committed to improving diversity and inclusion on our campus. So oftentimes the question that Hannah and I get is, how do you start this process? And recognizing that every university, organization, institution have unique resources and also maybe unique challenges, barriers, facilitators, and things like that. But we wanted to provide our experience and to describe our process in hopes that you can take some pearls of wisdom to bring it to your own institution, organization, or university. One of the first steps truly is buy-in at the top level. So having those who are at the highest point of leadership really support the goal of inclusivity. Providing a welcoming environment where everyone belongs and everyone's diverse backgrounds is appreciated, valued, honored, and celebrated. So we were very fortunate to have our dean of our university, as well as our regional dean for our campus, Dr. Stagnell Green, be very supportive and committed to improving diversity and inclusion at the campus level, as well as the university level. So in the fall of 2020, we developed an ad hoc committee on diversity and inclusion. Next slide. And so the charge of our committee was threefold: to assess the culture of our campus as it relates to racism, discrimination, and bias, and then provide specific recommendations, including strategies at the short term, intermediate term, and long-term goals towards improving the culture of our campus. So we wanted to sort of identify those low-hanging fruit, as it can be described, things that can be done immediately, but then also things that could be done that might take a few more years, and then long-term. And we wanted to make sure that the things that we identified would be sustainable, so that it wasn't relying on people, individuals who may leave the university and then the programs leave with them. Next slide. So our first step was to identify individuals who represented our campus. We realized that in order to address diversity and inclusion, it would take more than one or two people. So we really wanted to make sure that we included individuals who were involved in some capacity with our campus, with our medical students, so that we would have diverse opinions and views and perspectives. So what we initially did was send invites to faculty, staff, residents, and we wanted to make sure that all roles were covered. And then we enlisted the help from our medical student council, as well as our student committee of diversity and inclusion, which was developed in November of 2019 to help us identify interested students to be involved. And we didn't want to have just one student involved. We wanted to have multiple students, because we understood the rigors of medical school and how challenging it might be to be able to fully participate at all times. So, and we also didn't want any one student to feel isolated as well. So once we were able to invite these individuals, and actually initially we wanted to keep we wanted it to be a very small group because we wanted to work really fast. However, there were so many individuals who were interested in being involved. We ended up having a larger group of about roughly 22 individuals. So our next step was to identify areas to address. Oftentimes when organizations are focused on areas of diversity and inclusion, they may focus on one area thinking that they're going to cover, that it covers everything. But what we learned is that, the medical school life is very complex and there's a lot of layers. And so we recognized that we wanted to address diversity and inclusion in multiple areas of not just the students' experience, but the faculty, staff, and resident experience as well. So these are the key areas that we wanted to address. Student learning environment, which included areas of wellness and mental health. Faculty and staff environment, which also included wellness and mental health of faculty and staff life on our campus. And both of these subcommittees that we created also included how to report mistreatment. We also included a student recruitment subcommittee, as well as faculty and staff recruitment and retention subcommittee, residency recruitment and concerns. And then we needed to really review our medical student curriculum and identify ways in which we can include issues around structural racism, implicit bias, and recognizing that oftentimes in the medical school curriculum, those type of issues typically are centered in one course, when really there's ways to integrate it throughout their medical school career. And we wanted to make sure that we address those issues. We also included faculty and staff development, so training on how to be anti-racist. External impact, we value our community partnerships and really helping our medical students understand health disparities, understand how to advocate for patients, how to treat our diverse populations. So we also wanted to make sure that we address diversity and inclusion in that area as well. And then lastly, we recognize that assessment and evaluation would be really important. Now, because both of myself and Hannah's background is in assessment and evaluation, that was a pretty easy one for us. But oftentimes, organizations will miss that. They will miss thinking about, once you develop programs, how do you determine success? Mm-hmm. So one way to do that is through assessment and evaluation. Okay, so now how do we really start? We've done some background work to mobilize and organize a committee. We created subcommittees focused on those different areas that I described. Now what? So because of our background, we realized that we needed to start with assessment, actually. So we needed to assess the current climate. And so we wanted to reach out to our medical students to get a better understanding of their experiences of racism, discrimination, and bias. We also wanted to elicit from them their suggestions and their ideas on how to improve diversity and inclusion, because what we recognize is that while we think we know what medical students want, they are really the experts on their experience, and they needed to be very involved in that process. We also ran into an issue of, because of the current climate right now with COVID-19 and changes with the curriculum due to COVID-19, the social injustice that we're experiencing, that it's taken quite a toll on our medical students. And so there were some concerns that because they've been inundated with surveys and emails, related to changes, daily changes sometimes. And we were also concerned about students feeling as if they had to justify their experiences of racism, discrimination, and bias. And so we didn't want to do a more comprehensive assessment, which we had initially thought about doing. And so we did get feedback from our medical students and the student groups on their feelings about this. And we decided to sort of meet in the middle, that we would still do an assessment. However, we would make it brief. And we would use mixed methods, quantitative and qualitative, so that medical students, if they weren't comfortable, they didn't have to describe their experiences. They can just simply say yes, no, they've had the experience. And for those who wanted to vocalize their experiences and vocalize what suggestions they had to improve diversity and inclusion, they can do that as well. And then we also reviewed historical trainee data. So that's also really important for your organization, institution, university, to go back and look at data that you've collected previously. AAMC has some data on diversity and inclusion, and we were able to reach back to look at some of the previous data, as well as our internal surveys and evaluations that have been done in previous years. So we decided to make sure that we have regular meetings with our ad hoc committee. So our committee met twice a month, and then subcommittees met alternating weeks. And we didn't have any co-leaders, and we did that strategically with purpose, because to highlight diversity, we wanted to make sure that we didn't have one person leading the discussions, or even possibly even unintentionally taking over discussions. And we wanted everyone to have equal opportunity to participate, especially those who may be less likely to really speak up. So we wanted to provide a more nurturing, safe environment where everyone's opinions counted and would be valued. And it actually worked out really well. And then Hannah and I met with all the subcommittees. Sometimes we both met with subcommittees, or depending on our schedules, one of us would meet with the subcommittees, mainly to really help facilitate discussions, to help create a language, and to really sort of support our members as we move through this journey. So once our committees had met several times, subcommittees met, we then had to really sort of think, okay, what do we do with all of this information? And so we really utilize our assessment and evaluation subcommittee, not only with providing the earlier survey, but also going through all of the subcommittee's work and sort of compiling the data, compiling the, synthesizing the recommendations to create our final recommendations. And then as co-chairs for this committee, Hannah and I went through all of the recommendations and identified what we thought were priorities. And then we sent this out to our ad hoc committee to get their views, opinions, and agreement. And if there were any differences, we can talk through it and make some final decisions. So that was our process. It certainly isn't an easy process. It's a necessary process, but we did it in a way that valued each individual who participated, and really for being able to provide strong recommendations to move forward our diversity and inclusion efforts.
Great. Thanks so much, Alesia, for providing that detailed overview of our process. And we do hope that by sharing this information with you, you can take this back to your own organizations and work and apply some of those principles and lessons learned that we shared today. So that concludes our presentation. Again, we want to thank you for joining us virtually this year for our National Rural Health Day celebration, as we are also following the mitigation measures because of the COVID-19 pandemic. And with that thought too, I wanted to close by thanking all of the frontline healthcare workers that are responding to this COVID-19 pandemic right now in rural America. It's being especially hard hit. And so we want to recognize your sacrifices from the public health side and from clinical practices as well. And your sort of dedication continues to motivate us in our work as well. So thank you for that. And if you have any questions, we will share our contact information as well when we post this presentation. Thanks so much for joining us.